Responsible for any content, information, or opinions expressed. User bears full responsibility for their reliance on such content, information, or opinions.
Amp2.tv presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hi everybody, welcome back to another episode of You and Your Doctor, sponsored by All County Healthcare. We are a certified home healthcare agency servicing Palm Beach County, Broward, and Miami-Dade, and you can reach us at 954-717-7027. I am your host, Louise Gomez. Thank you for tuning in, and today we have Dr. Matthew Lavelle, and Dr. Lavelle is at, he can be reached at 561-395-5733, and he's right here local in Boca Raton, 1601 Clint Moore Road, Suite 125, Boca Raton, Florida, 33487, and the website is ortho-surgeon.com. Also has another location in Boynton Beach. Thank you so much for joining us, Dr.
Thank you
Lavelle.
for having me.
We appreciate you coming and taking time out of your busy schedule and coming to talk to us and sharing with us a little bit more about what you do. And so if you could just share a little bit about your background and where you studied, and a little bit more about your humble beginnings.
So I'm originally from Michigan. Went to University of Michigan for an undergraduate degree in chemical engineering and then a master's degree in biomedical engineering. Went and worked in New York at Columbia on a heart and lung transplant team for a year, and was helping them design a membrane, kind of getting to know medicine a little more, and decided that I wanted to go back into medicine. So I moved back to Michigan, went to medical school, and then ended up down at the University of Miami for my orthopedic surgery residency training, and then went back to New York for a year to study hip and knee replacement, and specifically anterior hip replacement and robotic assisted knee replacement.
But that makes sense because it's kind of like lines up, right? Engineering or...
Yeah, it's the same thought process essentially, and I think that's part of what drove me over to orthopedic surgery when I got into medicine. So. Yeah,
and so I guess you realized it kind of gave you clarity, right? Going into that in Columbia University, definitely. You realized, okay, getting closer to what I want to do. Okay, nice. I love that. And so just a little bit more about the location. What do I need insurance if I want to see you? Like what type of insurance you accept, or how does that work? So
the majority of my patients, I'd say, are Medicare based. And then, you know, each individual insurance, we take the majority of them, but kind of insurance by insurance basis, but a lot of Medicare patients, especially in the hip and knee replacement age population.
So what is the age range of your patients that you're seeing?
So really I'll see anyone from in their 40s up through their late 90s. There's a broad range, just addressing hip and knee pain with a variety of treatments, including hip and knee replacement and also other conservative options for that. And then can also just see any orthopedic issue, and you know.
So how does it start out? I go to your office and I say, you know what, like I don't know, like this is a true story now. Yeah. I fell down the stairs and I you know, sprained my ankle, but then after that it's like, okay, now I'm like I'm walking a little funny. So is that how it's?
No, it's that's a common presentation. You know, once you injure one of your lower extremities, whether it be an ankle, your hip, your knee, you start favoring the other side, and it can bring out some other aches and pains and makes you aware of them. So that's a very common thing that people come in with, something simple as a little slip, and then it really wakes you up to some of those pains that maybe you've had for years but haven't really noticed that much.
Right. So in that case, like, what do you do, like x-rays, MRI? Like how does what?
Yeah, a
the
lot of times we'll start with basic x-rays that will show us some of the bony anatomy and see if there's any abnormalities there. Beyond that, we'll do an exam, and then MRI can be very helpful in looking at soft tissue injuries, whether it's ligaments, muscles, and sometimes that's necessary, and a lot of times just based on x-ray and physical exam, we can figure out what's going on and get the problem addressed.
So how quick is, because, people are, as we age, we get a little fearful. How quick are we to say, okay, you need a hip replacement, or can you work around it if someone has pain, or what are some options?
It's an excellent question, and everyone, it's kind of a case-by-case basis. Sure. There are a lot of different conservative measures that we have to try to address this hip and knee pain, or whatever area is hurting you, but physical therapy can be a great asset, getting people more mobile, stronger, get their stability back, and get some of that range of motion back.
Right.
Beyond that, anti-inflammatory medication, whether it's Tylenol, Advil, can be a great addition to it. When we're talking about the hip and knee specifically, weight loss can be a great thing. So when every pound that you have, 3 to 5 pounds, or 3 to 5 times that goes through your hip and knee joint. So a loss of 10 pounds decreases the weight application in your hips and knees by up to 50 pounds. So, that can be a big thing that's helpful for people.
That makes sense, right? Just trimming down on our weight.
Yep.
We don't have to put as much pressure on those. Yeah.
And then getting, a little closer to the surgery side, if those things aren't helping, we've got options of injections. So you might have heard of steroid injections, common thing that is done in a knee. It helps to decrease some of the inflammation, get someone more active, just calm down that acute exacerbation of the arthritis that's going on. Also can be used for the hip. The knee, we've got a couple other options, gel injections or hyaluronic acid to add back some of the lubrication that your knee naturally produced when you were younger, but with time produces less and less of it. So, and then stem cells is another big topic these days. That's what I was going to ask,
because that's really a hot topic.
Oh, absolutely.
Are people coming into your office saying, tell me about the stem cells?
So stem cells have been shown to help with a lot of these symptoms, but we haven't reached the point that they're regrowing the cartilage that's lost. So we still don't have a way to bring back that lost cartilage, but stem cells are a great way to address some of those symptoms and help people feel better in the short term. Now, once we get past all these conservative things and it's just not helping, and really what I tell patients is when this is getting to the point you can't do the things in your daily life you want to do, the pain is just too much, then we start considering a hip or a knee replacement.
So going back to stem cells, because a lot of people are listening, they're probably saying, how does that work? Can you walk us through the extraction and the whole?
Yeah, I don't personally do a lot of it, but we have some people in the group who do. And essentially you're taking a sample of blood and you're spinning it down to get the certain cells that you want to put back in, and then you're applying that to whatever joint or muscle group or tendon that you're treating with it. And the thought process is a lot of those factors that you're isolating can be helpful in the healing process.
So now, I know a couple of people who've had to have hip replacements. They explained to me that it was like bone on bone. And what is that all about? How does that happen to us? And they weren't athletes.
No, there's a variety of factors that come into play. Genetics can be a big factor, and you talk with patients who say, my parents needed this, and I'm kind of at the point. Weight can play into it. An old injury can definitely play into it, where if you don't have a smooth surface on that joint or a little irregularity can lead to the cartilage wearing down faster. And some of it's just age. With time, the cartilage wears out, and the cartilage provides the cushion on that joint. So as you lose the cushion, you lose a lot of that padding that you had, and the bone starts grinding, and that's what brings the inflammation and the swelling and a lot of the pain associated with it.
So tell us a little bit, if somebody gets to the point and they say, okay, you recommend a hip or a knee, whatever they need. Can you walk us through what would that be like? What is the time frame for the surgery, the recovery, and all that?
So generally, the surgery itself for both of them takes an hour to an hour and a half. Most of these are done with spinal anesthetic, hopefully avoiding general anesthesia. Some patients require general for varying reasons. So a lot more patients these days are going home the same day. Part of it's just based on medical comorbidities and what kind of support system you have at home. But there are still a lot of patients who stay one night overnight.
Okay.
After a hip or a knee replacement, you can walk the same day on it, and physical therapy will often get you up and walking the same day.
Hold on, did I hear this correctly? Can we backtrack? Can we rewind? So you're saying they can actually put pressure on that?
Put pressure on it immediately after the surgery.
Really?
So as soon as that anesthetic wears off, we get them up and moving with therapy.
So, what does the therapy look like? It's like a physical therapy routine that you would prescribe to them, and what is an average for a person?
Yeah, so it varies between hip and knee. So hip replacement really is just getting up and walking. The leg feels like it weighs 1,000 pounds for that first week, but as the muscles come back, you're walking more and more, using a walker for probably a week or two, and then progressing to a cane, and then really no assistive device after 2 weeks typically with that. By 6 weeks, I'd expect you to be probably around 60 to 70%, and by 3 months, 80 to 90%, and kind of getting that last little bit over the course of the first year. Knees, a little more work with therapy, getting that range of motion back, stability, muscles, using a walker for 2 weeks to 3 weeks, probably 50 to 60% by the 6-week mark, and then up closer to 70 to 80 by the 3-month mark.
Wow. So it sounds like you got a whole schedule that seems to be working for everyone. We're going to take a quick commercial break, but when we come back, we're going to talk a little bit more about the robotic knee replacement that I want to ask a couple of questions about.
Of course.
So we're going to take a quick commercial break.
All County Healthcare has exciting news for any and all patients with COPD or other respiratory ailments. Listen to what renowned pulmonologist Dr. Keith Robinson has to say.
Hello, I'm Dr. Keith Robinson, board-certified pulmonologist, medical director at Fusion Health Pulmonary Rehabilitation, and a board member with the American Lung Association of South Florida. We have exciting news for patients with COPD. We now offer IPV therapy at home, which has been demonstrated to improve airway clearance, decrease hospitalization, and improve quality of life of patients with COPD. Please call All County Healthcare for more information about this FDA-approved therapy.
For further information, call All County Healthcare now at 954-717-7027. That is 954-717-7027, or visit our website at allcountyhealthcare.com. You can also find us on Facebook, YouTube, Twitter, Instagram, and LinkedIn. Remember, All County Healthcare always puts the patient's needs first. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Thanks for coming back to You and Your Doctor. We have Dr. Lavelle, and he can be reached at 561-395-5733 right here in 1601 Clint Moore Road, Suite 125 in Boca Raton, Florida, 33487. So I'm intrigued by this, Dr. Lavelle. What really interests me, or what's fascinating to me, is the recovery time seems to be a lot faster than what we heard from years ago. Can you give us a little background and experience, from your experience as to what's going on?
We've made some progress on multiple fronts. One being the pain control, not being so dependent on the opioid medication and using multiple other medications with less harsh side effect profiles to keep it under control right from the beginning. Beyond that, minimally invasive approaches with the hips. The anterior approach, or from the front, is more of a muscle-sparing approach than a traditional posterior approach, which was through the gluteal muscles. This has been shown to have a little faster recovery time, less likelihood for dislocation. And with the hips, also minimally invasive approaches, or sorry, with the knees.
So you're saying instead of going as they used to from the anterior, now they're finding it?
We're going from the anterior now.
You're going from the anterior.
The front instead of from the back.
Okay, got it. From the front and instead of the back. So that seems to be...
We can avoid cutting through the muscles. So it's a muscle sparing approach that helps with some of that pain and just getting patients moving faster.
I guess that's part of them being able to put pressure on it faster and easy and quicker, or?
Well, both approaches you can walk immediately after the
Really?
surgery. It's just kind of the rate which that you progress afterwards tends to be a little faster if you're sparing those muscles.
So what does a robotic knee replacement, so if I'm in your office and I say, can you tell me a little bit about this robotic knee replacement? Can I trust a robot? I know your hands I can trust, but I don't know if I can trust a robot. Like, you know what I'm saying?
It's a very cool technology that's really evolving, you know, even over the last 10 years, and each system has got a slightly different robot. One being taking a full CT of the knee so that we get a 3D image of it and can plan the surgery based off of that. Others just using data intraoperative, but they're all consistent. And what we're trying to do is get the angles, the rotation, the depth of the cuts to an ideal place for your knee. So we want this to mimic the kinematics of your knee as much as possible to get you back to functioning how you're comfortable on that knee. And the surgery itself is still done the same way, you know, the surgeon's holding the saw, but we've got all this extra data and assistance in the operating room to just minimize those outliers and get the patients back to where we want them to be using all this extra data.
That's fascinating. So do you find that seniors who have this challenge, are they more open to, I guess, this type of surgery? Because it seems like it's a lot less invasive, and it seems to be a lot more mainstream. I know back like 10, 15 years ago, it would seem like such a major surgery. Today it kind of sounds like I'm in and out, right?
So I think a lot of people are just talking with their friends and seeing how quickly they recovered and how good their outcomes have been, and that's really helped to raise awareness of, you know, the progression of our techniques and how we can really get people back to the lifestyle they want to have, much faster and less invasive than it used to be in the past and what patients believe it will be.
So can you give us any stories of maybe success stories of, do you have any patients who maybe were tennis players or, I don't know, whatever, joggers, runners, swimmers? What are some good...
I've got one patient who very active and used to be an active rower and a massage therapist and just debilitating arthritis in the hip that really prevented him from going up a set of stairs. And you know, he's one of those patients who you know is going to do well because he's a very hard worker and eager to get better, but he had tossed that walker aside, I think, the first day and was out walking 2-3 miles in the first week or two. And,
that's impressive.
You know, just some patients, you know, are very determined to move forward and work with therapy or do their own therapy. And you know, it's great seeing those stories. People have been so limited for so long, getting back to what they want to be doing in their daily life.
How much does mindset play with it? Like when you see a patient and you kind of gauge on their mindset and where they're at, how much does that play as far as their healing journey, like mindset?
It's definitely a big factor, and you know, sometimes before the surgery, getting someone working with therapy just so they can get familiar with even the therapist, some of the exercises, and mentally prepare for it can be very beneficial.
That's smart. So you would actually take certain patients and have them do it beforehand.
Yeah, it's something I offer to everyone, and you know, it could be very good just to kind of get them in that routine ahead of the surgery and prepared for the surgery.
No, that makes sense. It's a protocol that they're going to have, so you get them prepared for that. And how, on average, I guess everyone's different, but what do you think an average physical therapy session would be, let's say, for like a knee replacement?
So early on, a lot of the focus is just getting your range of motion back.
Okay.
patients who have been limited for a long time. It can take a lot to get that back and working through the pain. And with time, we'll start working on strengthening, just using your body weight and then progressing to weighted exercises, getting their stability back is another important one. So I'd say that's kind of the increment that we build up.
No, that makes sense. And are there, I think you mentioned there are other different types of options for maybe pain that people, maybe they want to, before they do the surgery, they want to maybe go through the journey of, well, let me try this injection first and whatnot. So you work with them on that.
Yeah. So, leading up to the surgery, we try to avoid opioids whenever possible, and a lot of it is the both over-the-counter anti-inflammatory medications I discussed, along with a couple options for prescription anti-inflammatory medications that are also non-opioid. We can try injections, but prior to a replacement, you have to wait 3 months before you can, like 3 months after a steroid injection before you can have a replacement, just to minimize the risk of infection. So that kind of gets factored in.
And on average, how long does a steroid injection, what do you think it would last a person?
It's a great question, and it does vary a lot. There are patients who get a steroid injections and we don't see them again. They do therapy, they do great. And there are patients that really have diminishing returns. So they'll come in, they'll get 2 or 3 of them, and they might last 6 months for the first one, and then 3, and then a couple weeks. So it really varies a lot, and kind of a patient by patient basis.
Now, is it because their body builds up like an immunity to it, or?
Perhaps, and I mean, really getting down to the root of it, we can't bring back the cartilage that's lost. So that inciting source, that bone-on-bone arthritis is still there, and it's still getting aggravated and causing this inflammatory response, and the steroid just isn't as efficient at calming down that inflammatory response they're getting from all that grinding arthritis.
Yeah. Now I definitely see why, as we age, going in the pool is really a good
pool's
option.
Great, absolutely.
Because that's what I did.
Similar to weight loss, it just lowers the weight on those joints.
It really is helpful, like just to go in the pool and just start doing those pool exercises, because you don't feel the pressure of, or doing certain things. Do you recommend people to do that?
Definitely. And there are a couple great aqua therapy places locally.
Nice.
Or even just going in your backyard and going in the pool. It's a great way to lower some of the pressure on your hips and your knees and get back, getting more active and helping with some of that weight loss too.
Oh, absolutely. So, Dr. Lavelle, we have about 3 minutes left. I usually like to, throw the ball in your court and ask you, do you have any recommendations for people who are maybe, I don't know, they want to get better, maybe they're sitting on the fence? With the couple minutes we have left, what would you, speaking to your audience, what would you tell them?
Yeah, so just kind of going back to those things we touched on, if you are developing this pain that's inhibiting your day-to-day life, and a lot of these different conservative options aren't helping you, you're trying those anti-inflammatories, maybe working with a therapist or even going out in the pool and exercising, you're welcome to come in anytime, and we can talk about some of these other options such as injections, or have further discussions about what replacement of the hip or knee entails. So those, I think, moving up that ladder, say from the least invasive to the more invasive, tends to be a good process to decide when you're ready for that hip or knee replacement.
And I like that because it kind of gets people mentally ready, right? Because it kind of puts them through that.
Absolutely.
So it's a good progression. Well, thank you so much for coming on the show.
Thank you for having me.
I've learned so much, and I appreciate you sharing all your knowledge and experience with everyone. Thank you so much.
Thank you for having me.
Absolutely. Great show.